Rapid vision loss after root canal treatment due to invasive fungal sinusitis, a case report published in ENT Journal in 2024 by Petrovic et al. Acute invasive fungal rhinosinusitis is a rare life-threatening condition characterized by the invasion of fungal organisms into mucosa, submucosa, and osseous structures of the paranasal sinuses. The leading causative pathogens of acute invasive fungal rhinosinusitis are mucormycosis and aspergillus. It predominantly affects immunocompromised individuals, including those with uncontrolled diabetes mellitus, hematological malignancies, or those receiving immunosuppressive therapy. The patient is a 69-year-old female with uncontrolled diabetes who underwent a root canal treatment with the placement of a crown for tooth number 15. Post-operatively, she was prescribed clindamycin, methylprednisolone, and NSAIDs for pain and inflammation management. Within a few days of the dental procedure, she began to experience progressive facial pain, trismus, and numbness on the left side of her face. 1 week later, she was evaluated by her primary care provider. No concerning findings were found on this evaluation, and the patient was discharged. 2 weeks later, the patient experienced a decrease in vision in her left eye, accompanied by ptosis and near complete ophthalmoplegia. The following day, this progressed to complete vision loss in the affected eye, and the patient presented to the emergency department with concerns for temporal arteritis, giving unilateral headaches and vision loss. Despite the patient having minimal to no sinus complaints, her CT was notable for ossification of the left side sinuses. She underwent endoscopic sinus surgery to treat the ossified sinuses, and she was noted intraoperatively to have copious purulence in the nasal cavity, but overall healthy appearing mucosa aside from areas of necrosis immediately adjacent to the location of the sphenopalatine foramen and within the maxillary sinus. Biopsies were consistent with acute invasive fungal rhinosinusitis secondary to mucormycosis. The patient underwent revision endoscopic surgery for debridement of necrotic tissue and drainage of infratemporal abscess and mapping biopsies to determine the extent of the disease. Interestingly, an examination of the oral cavity was notable for an additional area of necrosis at the location of the greater palatine foramen in the hard palate near her operated tooth. The patient was treated with injection of multiple antifungal medications and an additional 2 operative sinonasal debridements, and the patient was subsequently discharged on oral antifungal for long-term management, and they did not mention anything about the any dental intervention she went through along with her ENT management. If they extract the tooth, which is supposedly the causative factor of this disease, but they mentioned that after her last evaluation at 6 months post-discharge, she had only slight limitation to orbital abduction and had recovered light and shadow perception in her affected eye.